It's a very honor for me to present this session. This is the session number 5, entitled Acute Pulmonary Respiratory Distress. And really, we have an incredible lecturers. Firstly, we will listen Professor Combes from Paris. Then we will listen in Professor Schultz from Netherlands. And finally, Professor Mercat, also for France. Finally, Professor Laurent, who is from Canada, will make some question and some comment regarding each of the lecture. Professor Alain Combes, if you want, you can start right now. Thank you.
Hello, everybody. So I will discuss with you the potential timing and indications and actually where the ECMO for ARDS patients might be performed. So these are my disclosures. So what is the rationale for using ECMO in ARDS patients? There might be an indication which might not be discussed a lot now if those patients who are dying of refractory hypoxemia or refractory ARDS. In these patients, you have almost no choice of letting the patient die or putting the patient on ECMO. And there might be another group of patients actually who might benefit from these type of strategies. Those patients who are clearly less sick, who have severe ARDS, in whom the allowance of ultra-protective mechanical ventilation might reduce ventilator-induced lung injury and might actually translate in less mortality. So for the question of timing, there's been quite a few papers in literature discussing the impact of timing, and especially the use of very early ECMO in patients with ARDS. This is one of these studies we conducted in France in 3 centers, and in that study we showed that there was an increase of 7% in mortality for each additional day of mechanical ventilation before ECMO was initiated. So clearly, the sooner the better for this strategy, and on these slides you can see that those patients who got ECMO within the first week of mechanical ventilation had clearly better outcome as compared than those who got ECMO after 1 week. And it might be that ECMO was able to significantly decrease the intensity of mechanical ventilation in these patients. As you can see here, the driving was significantly decreased from 22 to less than 15, was just the tidal and the plateau pressure. Then we had the EOLIA trial, which is the latest RCT in ARDS patients, severe ARDS who received ECMO. There were actually 2 groups here, a group who did receive early ECMO and another group who received controlled mechanical ventilation on prone positioning. And there was also a rescue option for these patients. This is the EOLIA trial group, and I am really grateful to all these PIs who helped me in conducting this trial. And the paper, as you remember, was published in the New England a couple of months ago. We designed this trial as an RCT in which mechanical ventilation duration was stratified before randomization, and also was possible to include patients at non-ECMO centers, providing that these centers were experts in managing ARDS patients, and also that there was an ECMO recruitment team available right away to rescue the patient, set up ECMO, and transfer the patients on ECMO back to the ECMO center. The patients were randomized based on these 3 enclosing criteria, was mainly hypoxemia, and also the third criteria was criteria in which patient had severe decrease in compliance and became acidotic. The trial procedures in the ECMO group, patient received percutaneous VV cannulation with a low anticoagulation protocol, and mechanical ventilation was used as an ultra-protective settings with a PEEP of a 10 and a PEEP plat decreased to less than 24. The resulting driving pressure was less than 14. In control patients, we applied the EXPRESS strategy, the recruitment strategy of EXPRESS, with the PEEP set up to reach a PEEP plat between 28 and 30 centiliters of water. And there was also a strong recommendation in that trial for using a prone positioning for control patients. And also in case of hypoxemia, was possible to use recruitment maneuvers and nitric oxide. And we used the Cardinal device and Cardinal from McLeod for the study. And once again, there was a rescue option for severe control patients who did bad when the blood oxygen saturation went below 80% for more than 6 hours, despite the use of prone positioning, recruitment maneuvers, and nitric oxide. The results were analyzed in that study: 249 patients, 124 were assigned to receive ECMO, and 125 were assigned to the conventional treatment arm. Of these, 35 patients received rescue ECMO. The patient characteristic was just the same. Randomization was 6 patients, the mean PF ratio at 72 in both groups, and the driving pressure was on average 18 in both groups. So it was possible with ECMO to significantly reduce the tidal volume, the plateau pressure, and the driving pressure, as you can see on that slide, while the PEEP remained comparable between the two groups. Similarly, with ECMO, was possible to control hypercapnia. The PaCO2 was reduced significantly as early as day 2. Was the same for the pH, the PaO2, and the blood saturation, which increased significantly also very rapidly with regarding the management of patients in the control group, it should be noted that 90% of the patients who were prone, which is actually one of the studies in ARDS in which the use of prone positioning was the highest together with the PROSEVA trial. Virtually all the patients were paralyzed, and there were more patients in the control group who needed nitric oxide or recruitment maneuvers. The primary endpoint of that trial was deaths at day 60, and the rate was 35 in ECMO patients versus 46 in controls. Difference is 11%, did not reach statistical significance when comparing the two Kaplan-Meier curve. The p-value was 0.07. We also defined a key secondary endpoint in that trial, which was deaths in ECMO patients and deaths or crossover to ECMO in controls. And this time there was a significant difference between the two groups, 35 versus 57. And as you can see here, the p-value is less than 0.001 when comparing these outcomes. We also used another type of analysis, which is called the round-preserving structural failure time, to try to control for those patients who crossed over. And using this analysis, the p-value was just on the threshold at 0.005. The other endpoints, patients were on ECMO an average of 15 days. And this is also a major point of the EOLIA trial. All the secondary endpoints were all in favor of the ECMO group. There were less days with vasopressors, less days with cardiac failure, less days with dialysis or renal failure, and also less need for prone positioning of nitric oxide in the ECMO group. Those 35 patients who were crossed over to ECMO were crossed over after a median time of 7 days. And they were sicker at the entry in the study with higher plateau pressure, higher driving pressure, and also lower respiratory system compliance. And they deteriorated very rapidly in the last 3 to 6 hours with a huge increase in the need for inotropes. The lactate also rose, and the PF, when they were switched, was only 50. And these patients were quite sick, and 9 had cardiac arrest, 7 had severe heart failure, 11 developed renal failure, and of these 35 patients, there was a need for VA, ECMO for cardiac failure in 7 patients. In 6 of these, it was ECPR, ECMO for cardiac pulmonary resuscitation, and the CPR which was used. And when looking at the mortality, it was once again 35 in ECMO patients, was 57 in those patients who failed and who crossed over, which is very high, and was still higher in those patients who did not cross over, but were clearly less sick at the time they were included in the study. So now we might discuss a little bit why this trial actually may be considered as a positive one. When looking at the latest, all the RCTs performed in the last 5-6 years, the mortality in control patients was just the same or even higher, like in the heart trial. In control patients here in the heart trial was close to 50%. And look here, the PF ratio was close to 120. Once again, was less than 70. It was close to it was 72 in the EOLIA trial. We also do some sensitivity analysis in Eolia. This one here postulates that no control patients would have received ECMO even if they were very sick. And even if these patients would have survived without ECMO, 1/3 of these patients would have survived without ECMO, which probably is very unlikely. The results of the Eolia trial, the p-value would have still be significant in favor of the ECMO group. These were the conclusion of some editorial. This one by Jeff Grayson, which is the editor-in-chief of the New England. Dr. Grayson concluded that all the analysis point to the same conclusion. ECMO probably has some benefit in the context of severe respiratory failure, despite the fact that the trial was not traditionally positive. And he also pointed that all the secondary endpoints also favored the ECMO group. And very recently, we reanalyzed the data from Eolia using the Bayesian model, and it was published in JAMA a couple of weeks ago. And to make it short, using this model, it was demonstrated that the probability of ECMO being efficacious in these severe ARDS patients was between 88 and 99%, depending on the prior belief of the efficacy of ECMO. And once again, there was an editorial together with this paper telling us by Derek Andrews, who's the leader of the JAMA, that clinicians now should no longer ask does ECMO work, because that question appears to be answered by all these papers, and instead now we should ask by how much does it work, in whom, and at what cost, and I would also maybe add when and where should we go for this type of treatment. We might also have in the coming weeks some meta-analysis of the previous study, which might also may show that there is a strong benefit of ECMO. This is an algorithm here I will not discuss with you. That in detail will be published in the coming weeks. Also using the Eolia criteria to help you determine at what time and when the patients will receive VV ECMO. The last question, the 2 or 3 last slides would tackle also the question as to where the patient should be treated. And clearly, for this type of activity, we need high-volume centers because it's a complex procedure, and it has been shown that the limitation of ECMO centers is associated with better outcome, especially when looking on that paper from the major ELSO database showing that for adults here on the right side of the panel, it's probably needed to have at least 30 ECMO patients per year to reach here sufficient decent results. And this is also one of the suggestions here we made a couple of years ago together with the ECMONet, that maybe a minimum of 12 ECMO cases per year should be clearly the minimum to run such ECMO programs. And I think this is my last slide. I thank you very much.
Thank you, Professor Mercat. And the next turn is from Professor Michael Schultz from Netherlands. Please, it's your turn. Thank you.
Thank you for the opportunity to give a lecture in this grandiose meeting. It's exciting to have so many people listening to me while I should not move an inch from my chair, being here at the hospital. So when I accepted the invitation to speak on this session, I was asking myself the question, if the title is PEEP for all, should I stay with ARDS patients, or should I also discuss PEEP outside of the setting of ARDS? And I think this is an important question, because if we look at mechanically ventilated patients that we have to realize that many of our patients are having ARDS, but actually it's a minority of the total number of patients receiving mechanical ventilation. By the way, in ARDS, I think most well-performed randomized clinical trials are being performed. But there is another large group which is important. That's the patients that receive peri-operative mechanical ventilation, intra-operative mechanical ventilation. And I think there's an increasing number of randomized clinical trials of PEEP, or focusing on PEEP in this group. And finally, there's a much larger group, and that's the ICU patients not having ARDS, and unfortunately the studies that have been performed of PEEP in this group are old and usually poorly designed so far. So let me first try to explain a little bit how we think of the rationale for PEEP. And let's focus on ARDS because that's maybe the most easy way to look at it. So some of us might say ARDS, that's more or less a sponge model, meaning that air is the lung, and by giving a simple intervention like a higher pressure or PEEP, maybe we can solve this problem, so resolvence of atelectasis. But others would argue, well, maybe ARDS is not a sponge model, but a beer model. So water is taking the place of air, and in this case, probably a higher pressure is not so beneficial, is not able to replace the fluids. And this is nicely illustrated by this slide, maybe comparing two patients. One patient in which the use of a higher level of PEEP is increasing to some extent the aerated lung, but is also creating overdistension. While in other patients there is also some improvement, but not having overdistension. And I think this is, important to realize. If you give PEEP, you have less atelectasis, maybe, but you also have a higher risk of overdistension. Now, if you look at the studies that have been performed, let's jump into one Ipd Meter Analysis right away. This is a combination of 3 large trials that have been published over the last 10-15 years, approximately 2,000 of ARDS patients, comparing a low PEEP level to a high level PEEP level. In this Ipd Meter Analysis, when we focus on patients with moderate or severe ARDS, we get the suggestion that there is benefit from using a high level of PEEP. But importantly, if we look in this same publication and focus on the mild ARDS patients, actually with the use of high levels of PEEP, there is no mortality benefit, but these patients stay longer on the ventilator for a reason we cannot explain yet. But maybe we are causing some harm, and that's the reason these patients are staying on the ventilator for a longer time. Now, this was a really eye-opener for me, and I think for many people. This was the ARDS trial. I think all of you have read this trial and came to the conclusion that maybe this higher level of PEEP or super high levels of PEEP that were compared to a standard level or standard high level of PEEP was not beneficial. Actually, this study showed mortality, and this was really a shock, at least for me, because I was in my center a frequent user of higher or super high levels of PEEP. And interestingly also, when you look at these two Kaplan-Meier curves, there's a separation of the curves after 4 days. So some of you might say, this is because of the aggressive recruitment maneuvers that had been used by the group. But actually, the recruitment maneuvers were only used in the first day, and we see a separation of the two curves after 4 days. And in an additional analysis that has not been published yet, if you focus on patients in whom the higher level of PEEP resulted in a higher driving pressure, mortality was much higher than in patients in whom the higher level of PEEP resulted in a lower driving pressure. So maybe here is a signal that PEEP, when it's causing a higher driving pressure, causing overdistension, is actually harmful. So this is another way of looking at the benefit of PEEP. Now, of course, when there are new randomized controlled trials, there are always new meta-analysis like this one, and there's several others that will follow quite soon. This is the meta-analysis including the ARDS study, and if you sum up all the data, you actually are concluding that there is no mortality benefit at longest follow-up, ICU mortality or hospital mortality, and also with regard to the other endpoints like length of stay in the ICU or length of stay in the hospital. It seems that high PEEP is not beneficial in these patients. So I think most of us will start to agree that low tidal volumes is benefiting patients with ARDS. There's no doubt about that. Using a too low level of PEEP is creating atelectasis or allowing atelectasis with atelector trauma. A too high level of PEEP, or the so-called open lung strategy, as we sometimes tend to call it, is causing overdistension, and by that it's causing harm. Probably it should be something in between, a moderate level of PEEP, and maybe this is something that we should titrate or individualize. Now, how to do this? This is not so sure, but we are now in Amsterdam, and I think in many centers, now in favor of the lower PEEP, higher FiO2 table to titrate PEEP and FiO2. So this is the table coming from the ARDS network, and as I said, we favor the lower PEEP, higher FiO2 group. Now let's focus on perioperative ventilation, because there is an increasing number of studies focusing on the benefit or harm of PEEP in this group of patients. So PEEP in the OR. Use of PEEP in the OR is increasing, and this is maybe caused by some smaller studies like this one. This is an Italian study, single center, only some 60 patients, open abdominal surgery, in which a low tidal volume plus a high level of PEEP was compared to a high tidal volume plus a low level of PEEP. As you can see here, it's resulting in less postoperative pulmonary complications, what we sometimes tend to call ARDS of anesthesiologists, or ARDS caused by anesthesiologists. This is another study showing more or less the same. It's also a single center randomized clinical trial from China this time, spinal surgery patients. Also here we see that low tidal volumes plus a high level of PEEP and lung recruitment maneuvers is better with respect to development of postoperative pulmonary complications compared to high tidal volumes and a lower level of PEEP. And a strong evidence for this lung protective strategy, the benefit of this lung protective strategy is coming from this French study, 400 patients, published in New England now some 5 years ago, convincingly showing that there is benefit from the lung protective ventilation strategy, the combination of low tidal volumes plus high PEEP. But the question arises, is this benefit now the result of the use of low tidal volumes, or a high level of PEEP, or both? And we asked ourselves this question in the so-called Provilo study, which we compared two arms, a low PEEP arm, 2 centimeters of water, and a high PEEP arm, 12 centimeters of water. And in both groups, we used low tidal volumes. You can see this was a large trial, 900 patients, open abdominal surgery, and the main outcome is shown here too. It's showing that it's having no benefit with regard to development of postoperative pulmonary complications. And the same comes from a recently published Spanish study in which an individualized or titrated high PEEP level compared to low PEEP in 4 different arms, a large randomized controlled trial in Spain, approximately 1,000 patients, all for abdominal surgery, but it showed no benefit. Now, one of the critics you can have on this study is also comparing 4 arms. So the study arms are relatively small, and maybe that's an explanation for the finding, but you can also conclude maybe that a high titrated level of PEEP was not having benefit. And also here, maybe there's information coming from the driving pressure, or a signal that is suggesting that over-distension is harmful. So if you see that in the meta-analysis, if you see that the driving pressure rises in response to a higher PEEP level, actually there is an increase with regard to the postoperative pulmonary complications, a strong indicator that there is maybe causing over-distension. So to bring this one step further, and based on this small study of operating room patients, in which with electric impedance tomography it was closely watched what the level of PEEP created for atelectasis or hyperdistension, you may conclude that a certain level of PEEP may be the best level of PEEP with the lowest atelectasis and the lowest percentage of hyperdistension. But you also see from this slide that there's a wide range of PEEP. So while the median is 12, wide range is between 6 and 16, really meaning we have to titrate the PEEP level. And this is exactly something we want to do in a new study, which is under construction. We will start recruiting patients in the beginning of next year, in which driving pressure during general anesthesia is used to titrate the level of PEEP. It will be a large study, 2 arms, 1,500 patients, comparing 5 centimeters of water of PEEP, standard nowadays, versus a titrated level of PEEP. And again, here the primary endpoint is postoperative pulmonary complications. So let's move now to the non-ARDS patients. And I think this is an interesting group of patients because we noticed this in several observational studies, that PEEP is increasingly being used in these patients, sometimes as high as standard of liters of water. The question is this correct? Or is this also maybe wrong? So what we did in preparation of another randomized controlled trial that is running now in the Netherlands, we performed the meta-analysis. I was a bit surprised to see so many investigations, more than 20, but small numbers per study, up to 500 patients, in which a high PEEP level was compared to a low PEEP level, or PEEP was compared to no PEEP. And it does not matter in which way you analyze the data, but these meta-analysis data suggest that there is no benefit with regard to mortality or duration of mechanical ventilation. So you can ask yourself the question, is there then no benefit of PEEP or a higher level of PEEP in these kinds of patients? No, there will be patients that might benefit, at least suggested by this study coming from Brazil. It's a randomized clinical trial, 300 patients with hypoxemia after cardiac surgery patients, and a higher level of PEEP or an open lung approach with high levels of PEEP was resulting in a low severity of postoperative pulmonary complications. And as I said, we ourselves are performing a randomized control trial in the Netherlands. It's a completely Dutch trial with over 12 centers, which is running at this moment. 980 patients will be included, comparing the lowest possible level of PEEP, meaning PEEP is titrated to 0 centimeters of water, and as long as there is no oxygenation problem, it's kept at 0 centimeters of water, versus the standard in the Netherlands, which is 8 centimeters of water. And what I show here on the right side of the slide is pilot data for this study, in which you can see that we were quite easily reducing the PEEP level in these patients to 0 in a large majority of the patients, not paying a price of a higher FiO2 or need for a higher fractional oxygen level. So in conclusion, Chairman, I think for sure PEEP has positive effects. It's preventing or reducing atelectasis, and sometimes it's necessary to use a higher level of PEEP, but PEEP may also have negative effects, actually also with low levels of PEEP, creating overdistension, and it could be that overdistension is as harmful as atelectasis. I think PEEP should not be standard, but that is maybe now an open door or fixed to a certain level, like 5 or 8 centimeters of water. So PEEP titration is, I think, the answer, and future studies, future randomized clinical trials will provide us an answer whether we can use, for instance, the driving pressure during operation, or maybe in the ICU, or maybe the compliance as a readout for the best level of PEEP. This is where I would like to stop, and happy to take some questions later on. Thank you.
Professor Schultz, thank you very much for your very interesting talk. Yes, have you got any question?
Yeah, I don't know if Alain and Marcus are both online.
I'm online.
So Alain, we maybe going back to the ECMO, the indication of ECMO. So even if EOLIA is not strictly speaking a positive study, it's very convincing that outcome can be improved in specific patients by ECMO. So as you say, that as the editorial by Derek Angus said, we don't think we need to prove that ECMO can work. We are still a little bit struggling with the indications. And maybe one which you can discuss is that the late patients, because the most convincing data, it's an early indication. The patient is very sick, either from the ventilatory standpoint or from hypoxemia, and starting ECMO maybe in the first days, it really seems to be helpful for the patient. But if you wait, all the data suggests that the outcome is worse, and there may be reason related to the worsening of the patient, or it could be also that ECMO is less efficient. So the problem is that this will be a very frequent question, right? Because people will try to improve the patient, and especially if they are not in an ECMO center, it will take some time. So what would be your general recommendation? I know you cannot give a definitive answer, but and maybe recommendation for centers which are close to an ECMO center, and centers which are away from an ECMO center.
Yeah. No, it's clear, and of course, data from the EOLIA trial need to be interpreted in the context of EOLIA. EOLIA randomized patients only on mechanical ventilation for less than 1 week. We have also clear data showing that the mortality of patients who receive ECMO after more than 1 week of ventilation is less good. In our latest trial, the mortality was close to 50%, but still, half of the patients surviving, even those receiving ECMO late. So there's two messages here. First message is to build an ECMO network to discuss all the severe cases as early as possible, and all the centers should take contact with center expert groups in the care of ARDS patients and severe ARDS who might receive ECMO. And the second point, if the patient present with signs of severe ARDS after, let's say, 2 weeks, 3 weeks of mechanical ventilation, probably we need to be more stringent on the indications for ECMO. And clearly here, the age of the patient, the comorbidities, the degree of organ failure also should be taken into account. There's been 2 or 3 scoring systems, the RESP and the PRESERVE scoring system, which also might help in the decision. Clearly, after more than 10 days, 2 weeks of mechanical ventilation, the results are poorer, probably because the patient has developed more severe ARDS, and clearly the indication should be balanced in these patients against the risks and the mortality benefit.
Okay, thank you.
Sorry, Professor Brochard, I'm sorry, but we are ready to share the presentation from Dr. Mercat, okay?
Perfect, thank you.
I'm sorry, then then you can continue with the questions.
So in the next 10 minutes, I will try to discuss with you the potential benefits and risk of early spontaneous breathing in patients with acute respiratory distress syndrome. Next slide. This is my disclosure. Next. And so I think everybody would agree that at the very early phase of ARDS, we should use fully controlled mechanical ventilation in order to decrease the oxygen consumption and the CO2 production of the respiratory muscles, allowing to reduce ventilatory requirements, to control tidal volume, plateau, driving pressure to be sure to have a really protective ventilation and to prevent ventilator-induced lung injury, and of course to avoid agitation and asynchrony. However, this strategy of fully controlled ventilation first needs heavy sedation and paralysis. It may impair the hemodynamics. It may result in an uneven distribution of the tidal volume and in monotony, and it may contribute to atrophy and weakness of the respiratory muscles. So next slide. Next, Pablo, please. And so what are the potential benefits of spontaneous breathing in patients with ARDS? The first one is the more homogeneous distribution of lung aeration, leading to maybe a decrease in the risk of ventilator-induced lung injury and an improved gas exchange. The second is the decrease in the duration of diaphragmatic inactivity, and by this way, protection against ventilator-induced diaphragmatic dysfunction. A decrease in intrathoracic pressure, leading to an improvement in hemodynamics, and maybe a decrease in the needs for sedation, leading to an earlier weaning. Next, please. And so this is a slide just to explain the mechanism by which spontaneous breath may result in a better distribution of tidal volume. This results for a more even distribution in transpulmonary pressure, with a higher transpulmonary pressure in the dependent part of the lung with spontaneous breath, leading to a recruitment in lung tissue in the dependent part of the lung. Next slide. This mechanism has been demonstrated in many experimental studies, and this is one of the last studies showing this phenomenon with the CT and a color screening of the images and showing going from the top to here to the very high level of spontaneous breathing, a decrease in the quantity of tissue that is atelectatic when you increase the proportion of spontaneous breathing with a mode named APRV, a mode in which you give full pressure control breath, and you allow in the study the animals to have spontaneous breathing at any time during the mechanical ventilation. Next slide. And this is one of the data we have in humans. It is a study coming from Milan, from the team of Antonio Pesenti, and they use the electrical impedance tomography to assess the distribution of tidal volume in a group of patients recovering from acute hypoxemic respiratory failure, and they compared two levels of support. It was in pressure support, on the left with a high level of pressure support, and on the right with the low level of pressure support. A very low level close to spontaneous breathing without assistance. And you can see that with the low level of pressure support, the patient has the same tidal volume with the two level of assistance. And with the low tidal level of assistance, you can observe a better distribution of the tidal volume with an increase in the aeration of the dependent part of the lung. Next one. So this is to illustrate the interest of spontaneous breathing in terms of prevention of diaphragmatic atrophy. It is a very important clinical study by Johan Göllinger, published 3 years ago in the Blue Journal. The study was a study on the thickness of the diaphragm in patients on mechanical ventilation, thickness that was measured using echography. And these authors were able to demonstrate that, as expected, you have in patients who are completely inactive on full control ventilation, there is a progressive decrease in the thickness of the diaphragm, while with a degree of spontaneous breathing, this atrophy was prevented. And of course, in patients who made very strong and excessive efforts, they observed that probably due to edema of the diaphragm, there is an increase in the thickness, but it was let's say a side effect of excessive inspiratory activity. The idea is that preserving spontaneous breathing may prevent diaphragmatic atrophy, and by this way may facilitate weaning from mechanical ventilation. Next slide. But of course, there are some drawbacks of spontaneous breathing in patients with ARDS, some risk. First, there is a risk of an increase in the respiratory muscle VO2 and VCO2, leading to an increase in ventilatory needs. The second one is if inspiratory efforts are excessive, they may lead to high transpulmonary pressure and tidal volume, leading to the so-called patient self-inflicted lung injury. Strong inspiratory efforts may increase transmural pulmonary capillary pressure, and this may lead to a worsening of pulmonary edema. And finally, at least one study describes the occurrence of the pendulum phenomenon, what will be presented in the next phenomenon may lead to an increase in the risk of atelic trauma in the dependent part of the lung. Next slide. This is a slide from the paper published by Laurent Brochard, Arthur Schultz, Antonio Pesenti, describing this concept of patient self-inflicted lung injury. The idea is that in patients with acute hypoxemic respiratory failure, lung edema leads to impaired gas exchange and mechanics, and to a very high increase in the respiratory drive. And this high respiratory drive may lead to high transpulmonary pressure, high tidal volume, and that spontaneous breathing in this condition may contribute to aggravate the lesion. It is a so-called patient self-inflicted lung injury. And the idea is that controlled mechanical ventilation with protective settings may stop this phenomenon and protect the lung from this patient self-inflicted injury. Next slide. This is a very important experimental study from Takeshi Yoshida, who is one of the best experts in the field. It was a study in rabbits, and he was able to demonstrate that while in animals with, let's say, it was a model of ARDS, with a mild lung injury, spontaneous breathing was protective. But in animals with severe acute respiratory failure, spontaneous breathing resulted in an aggravation of the lesion due to very strong and inspiratory effort, leading to high level of transpulmonary pressure. And it is one of the risks, the major risk of spontaneous breathing in patients with ARDS. Next slide. This is to illustrate the Pandel-Luft phenomenon. It was published in the Blue Journal 5 years ago, both in humans and animals. And this phenomenon is linked to the fact that at the beginning of the inspiratory effort, at the very early beginning of the respiratory effort, there is a redistribution of gas from non-dependent part of the lung to dependent part of the lung. And this phenomenon may lead to opening and closing the dependent part of the lung and may increase the risk of ventilator-induced of lung injury. Next slide. And very interestingly, in a study published this year, once again in the Blue, it was a study done in animal models of lung injury and in humans with ARDS. And these authors, Morin et al., were able to show that high PEEP, increasing the level of PEEP, resulted in a more homogeneous distribution of pleural pressure and then a more homogeneous distribution of aeration, and very interestingly, in a lower level of inspiratory effort. It is illustrated on this image with here airway pressure. You see at the top airway pressure with an increase of PEEP. And as you can see, immediately after the increase of PEEP, this is the esophageal pressure. But it's the swings of esophageal pressure in this patient who is breathing spontaneously. You can see he is on assisted mode of ventilation. You can see an immediate decrease in the intensity of inspiratory effort. So the message here is that maybe if you use a strategy allowing spontaneous breathing, you should associate a high level of PEEP. Next slide. And this is a study coming from the group of Toronto, the group of Laurent Brochard, comparing 3 modes of pressure preset ventilation. And these 3 modes are different according to the level of synchronization. There is assist control ventilation in pressure, that is fully synchronized. Every inspiratory effort results in a pressurization by the machine. It is the black bar. Then the white bar, it is pressure control synchronized intermittent ventilation with the partially synchronized mode. And the last one is, let's say it is named here pressure control intermittent mandatory ventilation. The name could be BiPAP and Drager ventilator, for example, or APRV BiPAP. In this mode, there is no synchronization between the efforts and the pressurization of the machine. And you can see on the right that when you decrease the level of synchronization, the mean tidal volume decrease, and as expected, and the variability of the tidal volume increase. Next slide. And it is what that is observed here. It is a mode without any synchronization. let's say it can be named pressure control plus CPAP. You can see that the patient has several supported controlled breath in pressure, and it can make inspiratory effort at any moment, and the inspiratory effort will result in an unassisted breath without any synchronization. Next slide. And this mode was shown in this study that was published nearly 20 years ago, I think, by Christian Putensen. This mode was compared to pressure support or to pressure control in a small group of patients with acute respiratory distress syndrome. And Christian Putensen was able to demonstrate this mode. It was a physiological study, and this mode resulted in a higher level of cardiac output and a decrease in shunt and an improvement in PO2 compared to both pressure control and to pressure support. And in the three modes, there was the same. The three modes were used with the same level of expiratory pressure and the same level of inspiratory support. So the idea is that a pressure preset mode without any synchronization, allowing spontaneous breathing, fully spontaneous without any support, could result in an improvement, as you can see, in shunt, suggesting a decrease in a recruitment maybe of the dependent part of the lung. Next slide. So to conclude on spontaneous breathing in patients with ARDS, animals and clinical studies suggest physiological benefits. There are possible drawbacks in case of excessive efforts. A mode without any synchronization should be preferred, with a sufficient level of PEEP, and this strategy should be associated with a high PEEP strategy. Excessive ventilatory effort should be detected, and it is not very simple. Maybe it could be a very important role of the monitoring of esophageal pressure, and this excessive ventilatory effort should be avoided using sedation. And of course, the benefit on outcome remains to be demonstrated. Next slide. It is the reason why, with my two friends, Jean-Christophe Richard and Laurent Brochard, we designed some years ago a multi-center randomized control trial, including 700 patients with moderate or severe ARDS. And this trial compared assist control, volume assist control, to this mode named BiPAP IPRV. And this mode was set in order to obtain a spontaneous breathing activity representing between 10 and 50% of total ventilation. And in the two mode, the settings of the support was should have resulted in the same tidal volume of 6 ml per kilogram predicted body weight. There was the same PEEP strategy, that was a PEEP that was described in the EXPRESS trial, the high PEEP strategy of the EXPRESS trial. The same strategy for sedation and weaning, and the primary endpoint is hospital mortality. And we have now ended this study. 700 patients have been included. The analysis is ongoing, and we hope to be able to submit the study for publication in a few weeks. I thank you.
Maybe I'll start first with Alain Mercat, because Alain, you just finished. And maybe discuss about what should be the monitoring for patients breathing spontaneously. Maybe, let's say, from the simplest to the most sophisticated. If we are concerned that we don't know exactly if the patient is on the good side of spontaneous breathing or on the bad side with the risk you describe, maybe we'd like to monitor what the patient is doing. So what do you think we can use? And again, from very simple things to much more sophisticated tools.
So I think it's a key issue. The first very simple thing is to monitor tidal volume, because as expected, if the patient make a strong effort, it will result in high tidal volume. But it is not so simple, because in this patient with, especially in patients with severe ARDS and with low compliance of the respiratory system, strong efforts could result in a tidal volume that can be considered come not very high. The first step still is a level of tidal volume. For example, in the trial, in the birth trial, we asked the center to set the alarm values of inspiratory tidal volume at 8 ml per kilogram predicted body weight in order to avoid to recognize early strong efforts leading to high tidal volume. I think the second tool that can be used is the PO1, because the PO1, which is a measurement of the drive, in fact, we know that, as you perfectly know, Laurent, especially because you are one of the authors of the, I think, one of the first studies on this topic, in patient on assisted mode of mechanical ventilation, there is a correlation between PO1 and the work of breathing, is the intensity of the inspiratory effort. And the PO1, let's say higher than 4 or 5, is indicative of a patient who is making very strong efforts.
So the PO1, Alain, is what is also called the occlusion pressure.
Yeah, okay, and it is available. It is available on all modern ventilators with a special maneuver, or in some mechanical ventilator without any special maneuver. It is continuously indicated on the screen of the ventilator. So it is very, very useful. I think it is not frequently used in many ICU, at least in France, it is not very frequently used. But I think
if you wanted to make some recommendation, would you have some numbers to recommend?
Let's say that higher than 5, it's usually PO1 higher than 5 is usually associated with strong efforts and maybe too strong efforts. Okay. And the last tool, of course, is the esophageal pressure. And now it is quite easy to have a monitoring of esophageal pressure by connecting an esophageal balloon using, for example, we use in my unit a nasogastric tube that is used for nutrition, and who has a balloon in the esophagus, and it is quite easy to connect this balloon to a pressure transducer we use for monitoring vascular pressure, for example. All the system is filled with air, and the transducer is connected to the monitoring system. The only thing you have to remember is that you have to translate millimeter of mercury in centimeter of water, because we are in respiratory physiology. On the screen of the monitoring system, you will have the value in millimeter of mercury, but it is very easy by this way to recognize, to assess the intensity of the inspiratory effort. And now in some mechanical ventilator, we can connect an auxiliary pressure, and it can be shown on the screen of the ventilator.
Okay, thank you very much, Alain.
Thank you.
Marcus, you're still there, I guess.
Yes.
So Marcus, you try to address a very, very broad topic, right? PEEP in all kind of patients in the ICU. And I have 2 questions for you. The first one would be, let's say, you discussed ARDS, you discussed non-ARDS, and you discussed intraoperative ventilation. Do you think the objective of PEEP is the same in all categories, or are there fundamental differences in the goals of PEEP in these 3 categories?
Yes, I think that's a very good question. So
yeah.
I think your question is very important, and it's maybe relating to one of my first slides in which I compared lung to a sponge and to a glass of beer. I think in ARDS we are more looking at a beer model in which we may have complete other situation than the simple atelectasis that develop during surgery caused by induction anesthesia, for instance. That's one thing. And the second thing is, what is the goal of using a high level of PEEP? We always have been thinking that a better PF ratio or better oxygenation is the goal to go for, but maybe that's not the right goal. Maybe, yes, you have some better or less shunting, and as a result of that, you have a better PF ratio, but it's not resulting in a better outcome of patients.
Mm-hmm.
So yes, it's different. If you look at ARDS patients versus intraoperative ventilation. And another important thing is that although I was talking about non-ARDS patients, and when you look closely at studies performed in non-ARDS patients, these patients were at high risk of developing ARDS. And
Okay.
sometimes I'm not so sure if what we call non-ARDS is truly non-ARDS, or whether we should not consider them to have a certain overlap. What is
Okay.
mild ARDS versus non-ARDS, for instance?
Okay, great. And I have a second question for you. In the field of ARDS, we think that PEEP is not only important, but it's absolutely mandatory to use some PEEP level. And all the experimental studies looking at ventilation with ZIP always showed worse results. So I think nobody is proposing ever to ventilate patients with ARDS in ZIP. I think even for the sake of ventilator-induced lung injury, since the very first studies, we know that PEEP is protective. So some PEEP is important. So my question for you is, if we look at the whole ICU population, all patients, are there indications to ventilate a patient without PEEP?
Well, I would like to turn the question around and ask myself the question, are there indications to use PEEP, and then how much PEEP? So I think historically seen that, yes, you're right, and I agree, when you have ARDS or moderate severe ARDS, or you have severe oxygenation problems, PEEP is beneficial and protective. But we should not translate that easily to if it's protective or effective in ARDS patients, then it will also have beneficial effects in the non-ARDS patients or in the operating room, because PEEP is not only having effects on the lung, but also, for instance, on the circulation. So I just want to be sure and certain that everybody understands that I'm not propagating that we should not use PEEP, or a lowest level or very low level of PEEP in ARDS patients, but we should be careful in translating it to high PEEP is good, so why not use high PEEP in all patients?
Yeah, that was not my question at all, Marcus. I'm not saying, I'm not asking if we should use high PEEP in all patients. I'm asking, do you think there should be patients ventilated with no PEEP at all?
Yes, thank you for repeating the question. It could very well be that there's some patients that have benefit from using no PEEP when they are still having ARDS. But that's very difficult to determine at the moment. So for instance, you can think, if you are applying a level of PEEP and it results in a rise in, for instance, the driving pressure, suggesting that you're only creating overdistension, then in those patients I would go for a lower level of PEEP, or accept that there is some atelectasis, or sometimes there may be even a lot of atelectasis, which I then should try to solve with a higher FiO2 level if my PO2 level is too low. Is that answering your question?
No, I think you're still in the field of ARDS. Well, personally, in the field of ARDS, I would say there is absolutely no indication to ventilate patient in ZIP, but that's based on, of course, on clinical experience, as we all have, but also on all the literature, which is very, very consistent.
Yeah.
No, my question was about non-ARDS. Should we ventilate all patients in the ICU with some degree of PEEP? I'm not saying high PEEP, but some level of PEEP.
Yeah.
Or should the standard of care be without PEEP?
Yeah, so this is actually a question that we try to give an answer to with the RELAX trial. It was one of the last slides I showed. In this study, we specifically ask ourselves, so can you ventilate the non-ARDS patients without PEEP or with the lowest possible level of PEEP? That is the level of PEEP at which you have an acceptable PaO2 level. And I think the answer could be, but I don't have the results of this study. We're only on a quarter of our patients. We did not do an interim analysis. We're not planning to do so. I think there will be a majority of patients not fulfilling the criteria of ARDS that can be ventilated with the lowest possible level of PEEP, which is actually 0.
Hi, dear colleagues. I'm sorry, but we are on time. I understand this is one of the most excited sessions from the afternoon. At least in Madrid, this is the afternoon. But we have to stop and move on to the next session. Thank you very much, Marcus, Professor.
Thank you.
Thank you.
Thank you.
Thank you.
And I hope to see you next year, to all of you. Thank you very much.
Okay. Thanks.
El proyecto UCI Zanzíbar comenzó en agosto de 2016 gracias a la colaboración junto a la Fundación NED y muchos voluntarios, aprovechando que el gobierno de Zanzíbar había construido una nueva unidad de cuidados intensivos en el hospital La Simolla, que inicialmente estaba infrautilizada. El personal no tenía mucho conocimiento en cuidados críticos, la enfermería tampoco era la más adecuada en cuanto a conocimiento unipersonal y en cuanto a materiales, etcétera. Y bueno, desde que empezamos nosotros
¿Estás por ahí?
iniciamos un proceso de formación del personal local de Zanzíbar. Junto a múltiples voluntarios que hemos ido yendo durante estos 2 últimos años, hemos conseguido pues grandes mejoras.
Para mí, el proyecto UCI de Zanzíbar ha supuesto un antes y un después a la hora de entender la medicina. Es curioso cómo cada vez que he ido he aprendido muchísimo más de lo que he enseñado. Yo creo que es una experiencia que no deja indiferente a nadie. Es única. Enriquecedora.
Sorprendente.
Apasionante.
Esta experiencia ha sido un desafío personal y un desafío profesional.
Evolución. Transformación.
Agradecida.